I'd like to introduce Anthony Wright, who's going to moderate our next panel. He's Executive Director of Families USA. Before joining the organization, he served 22 years as Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition. Under Wright's leadership, Health Access California led state efforts to win patient protections, fight budget cuts, invest in the safety net, and expand coverage. So thanks for moderating this panel.
Good afternoon. All right, all right, I know it's after lunch for you folks, but we're gonna have to, good afternoon. All right, can I have the speakers come up? And obviously in my federal role, a lot of the things that, would be weird if I didn't acknowledge the fight that we're going on literally as we speak, in Congress with regard to Medicaid that has such an impact on this conversation just in terms of the substance. And, we saw the chart about what Medicaid expansion means or doesn't mean for medical debt, the specific provisions of the bill that include increasing cost sharing for some of our lowest income people. That could be $35, could be over $1,000 added up for a low-income person, but also just even the theme of the conversations about what kind of burdens do people have in terms of paperwork to prove income and all sorts of other verifications, and should the burden of these systems be on the individual patient or on the system? The burden of just proving your income, proving your eligibility, when so much of our life is automated, but to get health care, it seems to be so complex, confusing, even Kafkaesque. But I am really here and excited about this panel because as much as I enjoy my new federal role, I spent the last 30 years as a community organizer and state advocate, working with some great people in this room. Can I actually raise hands for those folks who are state advocates in the room? Yes. Because it's always been the case, but especially now in the next several weeks, that the action is in the states. That's where, especially with some of the dreariness of the federal landscape, that there is a lot of activity in the states about where we can make progress. And we have great examples here that we're going to get into in a second. Again, my own background, having privilege to be a state advocate for 30 years in New Jersey and then for the last 2 decades in California, was on issues, whether it was last year on California passing a bill to take medical debt off credit scores, or in 2006, the Hospital Fair Pricing Act that set in place policies so that the uninsured cannot charge more than Medicaid or Medicare for hospital care. But I will contain myself from interjecting too much about my California experience because let me quickly introduce them. Again, some of the best and brightest in this field, starting with Elisabeth Benjamin, Vice President of Health Initiatives at the Community Service Society of New York. Then Nicole Dozier, the Director of Health Advocacy Project at the North Carolina Justice Center. Then Luvia Quiñones, the Senior Director of Health Policy at the Illinois Coalition for Immigrant and Refugee Rights. And then Maanasa Kona, the Associate Research Professor at the Georgetown University Center for Health Insurance Reforms, who will give us a broader perspective of what's going on in all 50 states. But my first question that just have is for each person to name, and Maanasa might be able to have a broader view, but for in each of your states, one exciting policy development happening in your state on medical debt that you want everybody to know about. Who wants to start?
I just got voluntold to go first. That happens often. Thank you, everyone. So because of the great work that advocates did around Medicaid expansion, when we would travel the state, medical debt came up very often. And so in meeting with HHS leadership and asking us what was next for the Justice Center, we said, let's work on attacking medical debt. And that individual said, "Oh, I like that idea." And so from that, we have a really exciting HHS medical debt program, and it's so much to it. I do have to look at my notes, but I mean, essentially, you're talking about All the 99 hospitals, critical care hospitals, signed on to this. Some were happier than others. We can talk about how we got to 99 later. But by January 2025, each of the hospitals had to have a mitigation program, and that had to be in plain language, which we know doesn't happen very often. But the goal is to have presumptive eligibility, to cut red tape, and also thinking about that hospitals had to provide discounts for people at 50 to 75 and 100% of based on their income and family size. And then interest rates capped at 3%, payment plans capped at 36 months, not to exceed 5% of the total household income for people at 200 to 300% of federal poverty level. And then rolling out other things, through July 2025 and 2026. I don't want to talk longer than I need to, but it's exciting. I don't think there's anything like that in the country. For that to happen in the South, it happened in North Carolina. Yeah. That really is due to the funders who supported us, like Community Catalyst, Arnold Ventures, and other partners like Bernita in the room, to help us look at some of the things that we're looking at, and got us to even some more exciting things later that are actually proposals in the legislature. So I'll stop there.
Thank you. Luvia, do you want to go next?
Sure. So I'll focus on one of our successful campaigns. So quick background, we're a statewide advocacy coalition. And even though our main, you could say, audience and people that we serve are immigrants, when it comes to our medical debt work, we made the strategic decision to focus on uninsured when it comes to the messaging. For many reasons that I won't get into. So over the years, one of the things that we continue to find is, despite having all these different state laws that said a hospital is supposed to have a sign that promotes financial assistance, the hospital is supposed to put this in a medical bill that people could call. I won't get into the language barriers and many other issues our community face, but I want to focus a little bit both on the different state laws that we technically have and the lack of enforcement. One of the things that we continued to find is the number of people that had both hospital bills and were in medical debt, despite being eligible 100% for hospital financial assistance. So we're talking about people in our state, hospital financial assistance, anyone that lives in Illinois, is uninsured and is under 200% of the federal poverty level, qualifies for a 100% discount. Unfortunately, many hospitals, not all, but many hospitals do not tell uninsured that this is available. They just send them a bill. And I think across communities, specifically in the immigrant community, there is this notion of wanting to do everything right in case there's a chance of getting a green card in the future, okay? So when they would get a hospital bill, despite being very, very low income, they would set up a payment plan for $20, for $50, never probably being able to pay this $20,000, $50,000, or even higher bill. And what we kept on finding is, because of that lack of information, and we do a lot of health know your rights presentations, webinars, etc., there was no standardization. So we introduced a bill that would require hospitals to screen anyone that was uninsured. And if the person was found to be eligible, then the hospital would have the legal obligation to help the person apply for hospital financial assistance. I will say that as an advocate, for a person to actually submit all the required documentation is very burdensome. Imagine if you don't speak the language. Imagine if the application is only accessible on the website. So a lot of different issues. But after many negotiations with our hospital association, we were able to be successful and pass the law, and actually took effect in July 2024. And as of then, all hospitals have to screen uninsured and have to help people apply for financial assistance. If they're found eligible for other stuff, then they may be referred to the state Medicaid agency to buy insurance, etc. But at a minimum, at least people now have that opportunity, and it's lesser of the obligation, responsibility on the patient, and more so on the hospital.
Elisabeth.
I don't know. Oh, it is on. Okay, hi. So I think I'd like to talk about it. The one thing was our strategy. And we started an medical debt campaign because our consumer assistance program started seeing a 64% increase in medical debt cases in 2019. We're like, we don't see a 64% increase in anything, but we love to run data. And so it really inspired us to work on this issue because it was really something that was being experienced by our clients. And Kelly, was doing that work every single day. And we were just so grateful to her. And our strategy sort of we started out with kind of an omnibus bill and then peeled off the parts. So it's really 8 bills in one. But we just wanted to focus everybody's brains with the big omnibus Patient Medical Debt Protection Act. And then there were sort of 3 areas that we really worked on. We passed, by the way, 8 bills in 4 years, and I can get into the details. But what we figured out that about 15,000 people were being sued a year when we started in 2019 by all of our hospitals in New York State are supposed to have already had a financial aid application and are all 501c3 not-for-profit charities under state law. So we were like, wow, that's a big number. By the time we ended with our campaign, as of April in 2025, 125 people have been sued. So that's just it's literally like that. And so the strategy is basically 3 buckets. 1, work on what's going on with those lawsuits. Why are they, there's a bunch of sort of things that are very creditor friendly in our debt reform court, what goes on in court. And we just went through a punch list, no liens, no wage guardedness, reduce the statute of limitations from 6 to 3 years, no judgment interest rate, 9%, no one pays 9% interest, let's do 2%, just work that whole list. And then the second bucket of issues was really, and so that really impacts people who are being sued, like the most egregious cases. But then there's another way to get at medical debt is to really look at the credit report. And we love Colorado because they beat us by 2 months. But we were the second state to ban credit reporting. But we did a little different than Colorado because we made it illegal for the providers to report the debt as well as the credit reporting agencies to report it out. And I would love to take credit for that idea, but it was Bernita's colleague, Chi Wu at National Consumer Law Center that helped us write that. And we were so proud to get it over and it also covers care credit, by the way, and then the third thing, which was our holy grail, was really reforming our hospital financial aid law. And so uniform hospital financial aid application, all uniform eligibility standard, uniform documentation request, they can only follow these things. And burden of proof, nobody is allowed to be sued below 400% of poverty, and the burden of proof's on the hospitals if they do it. So in those 125 lawsuits that have happened this year, there will be an affidavit from the CFO claiming, I don't know how they're going to know it, that person has an income over 400% of poverty. So I think it's the strategy. And then there's just there's a whole organizing strategy that was a companion with that vision of what we wanted. And it's made a big difference. I mean, we can prove it. So.
No, it's great. And we will absolutely get to the organizing and strategy in a section, but I want to turn to Maanasa, who can talk about her medical debt work at Georgetown and this, because you study state policies across 50 states, and to tell us a little bit how these 3 examples fit into a larger tableau.
Yeah, sure. So just for a little bit of background, we do 50-state research on various medical debt policies and publish it through Commonwealth Fund. Our last report came out in September 2023. So I thought that it would be interesting to talk about what we've seen since then and what we've been tracking. An update is forthcoming shortly, but just to give you a little bit of preview of the sort of trends in state legislation that we've seen since then, I think it's helpful to think of it as the really super upstream measures and then going down to downstream measures. So the really upstream is, of course, strengthening coverage and then dealing with high hospital costs. And that I'm not going to steal the thunder of the systems panel that's coming up next, but moving one step down, you've got community benefits, a little bit attenuated from, solving the medical debt problem, but it still does contribute. The big goal is, to put money into the community in lieu of receiving preferential tax treatment. And the hope is that, tide will lift all boats. Have we seen any action on this front? Very little. This seems to be an area that states just don't seem to have as much appetite for enacting just as of yet. moving one step lower, we've got financial assistance, of course, also prevents the accrual of medical debt. We've, of course, seen New York as the one and only shining example for the most part that has done both pieces of it, which is to kind of target the standards of financial assistance, kind of expanding who's eligible for it and how much they get, but then also to kind of tackle some of the more procedural side of things. We've also seen some financial assistance procedural developments from California and Maryland, of course. I think they have like limited monetary asset consideration in the application, which does kind of ease the path a little bit. And then moving one step down, we've got billing and collections. Here we've seen definitely a lot more action. We've seen Delaware and Maine have the prohibited interest, and New Jersey and New York have limited and capped the interest. We've seen reasonable payment plan requirements. I know that Nicole was talking about North Carolina doing this. Also saw that from Delaware and New Jersey. But of course, the most active space, as everybody here probably knows, is the credit reporting ban. As Elisabeth was mentioning, we've seen a rise of like sort of the belt and suspenders approach of, on the one hand, prohibiting providers from supplying the information and then from credit reporting agencies from using that information. And occasionally we're starting to see a little mix of states also prohibiting the end user of the credit reports from considering that information in making their decisions as well. And this has been a completely active space. I think we're now up to 12, with Maryland and Washington just joining the ranks as of a couple weeks ago, which is fantastic. Congratulations. Then moving further downstream, you've got the lawsuit protections, which Elisabeth was talking about. We've seen some great movement in especially Delaware. They now fully prohibit wage garnishment and foreclosure. California kind of tightened up their liens and wage garnishment protections. And then we, of course, saw measures like in New Jersey where, those below 600% of federal poverty level cannot be, their wages cannot be garnished. So we've kind of seen activity across the board. And then much further downstream, we've got the debt forgiveness angle of it. And that is something that's also been equally as active as the credit reporting space in terms of states enacting a bunch of medical debt relief programs, which basically like buys and forgives. And I know undue medical debt has been very involved in helping states do this. And we've seen it not only at the state level, but also sort of like local and county levels as well. So we've got kind of action sprinkled across the spectrum, but it's been really focused so far on the credit reporting, billing, and collection side, except for New York, which does this great thing. They keep doing these recursive bills that like kind of plug holes as they go along, which is a great strategy, and it's a delight to see.
No, that's great. A lot of activity, and I think if you patch these together, it really does provide a whole like action agenda of what states can do in all these realms up and down the spectrum. And obviously, some of them are admittedly more piecemeal. Some of them are broader. Some of them are broken down into pieces, but build toward a bigger system of protection for patients. And so when we get to questions and answers, we'd love folks to dive into fleshing out what does this ongoing, evolving, and emerging agenda for state advocates and legislators and policymakers could look like. But I do want to move the conversation a little, because I want this to be both about information but also inspiration for what is for how, not just the what, but the how. How do we get this? So I would love to just also ask, what is one or two things that you thought was particularly successful, in terms of a strategy, in terms of information that you collected, in terms of specific type of coalition that you built? Anything that specifically comes to mind? Luvia, it looks like I've intrigued you. Go ahead.
Yeah, as you were speaking, I was thinking of all the stuff we had to do to get this over. And I'll say our approach was piecemeal, unfortunately, just because of the opposition. So I'll just say that, because what we started with was also probably at least 2-3 bills, but we just had to compromise a lot to get something. So for us, even before we introduced the legislation, as has previously said, I think it was in the morning session, when it comes to medical debt, we know that those that are affected the most are communities of color. So keeping that in mind, even before, again, we introduced legislation, we're very intentional on who are going to be our chief sponsors in the bill. So we chose somebody from the Senate side that is African American, and from the House side, somebody that's Latina. Because not only do they also come from the community, so understand the issue, but also to get the different caucuses on board. Additionally, we had, I don't know how many stories lined up from across the state, so they wouldn't think that, again, it was only a Chicago issue, because that's usually what we're told. It's the city issue. So we had from downstate, Illinois, et cetera. And to make sure that people knew, again, it was across counties, from different income levels, and even as many of us may know, the immigrant community is also very diverse. So making sure that the stories were not only Latino, but also from the Asian community, Arab community, etc. The other thing is that as we were going through the whole legislative process, committee hearings, etc., our main opposition, as has been said in other conversations, we did have to, put it nicely, fight with the hospital association that was very against many, many things in our bill, including private right to action, which we tried, but had a compromise on that one. But one of the things that they kept on saying in the various hearings was hospitals were doing everything. There was no issue. People were not in medical debt. People can access the services. And in our experience, and it wasn't 1 year, it was several years of having to help individuals navigate financial assistance, despite us not being a direct service organization, that through the help of many different partners, many of you in the room that we had to consult, we actually, right before the bill was going to be heard in the House, we organized not only a press conference, but a report that focused both on the national data on medical debt, but also on the Illinois data, thanks to Community Catalyst, thanks to, I'm going to draw a blank on the different names of people that I reached out to here, to really put in the focus on medical debt, that it was really about just this increased issue. And after the release of that, we took the various news articles. We got pretty much published in every newspaper in Illinois, as well as I think there was one at the national level, but I can't remember. And we started just distributing those news articles in the different offices, in addition to an executive summary. And the conversation shifted right away. Then it was pretty much no denying that it was an issue.
Great. Why don't you go?
So we definitely had a really, is this on? Yeah. We had like a ground game, and so I'm going to, yes, we did that. We love, all of that stuff, and town halls. And we also had like a really vibrant, We the Patients social media platform that had like client videos and stuff like that we got from the town halls that we did in all different areas of the states. Also, very important, not just having it be a downstate issue. 50% of the population lives in New York City in the state, and then the rest of it's like Appalachia, right? So with some pockets at like a couple of other urban places. So very different thing, but you have to win the whole state to win legislation. And I have to say medical debt is a wonderful issue in New York because it's a bipartisan issue. We had Republicans voting for it out of committee. We had Republicans voting for it on the floor. I think the strategy that I'd like to talk about that hasn't been talked about, I'm not sure anybody else will talk about, is we did this great, kind of a very ambitious thing, which is we have 210 hospitals in New York State, all of which are nonprofits, and we looked up every single hospital name in every single civil court database and amassed a universe of all the medical debt lawsuits. And then we started looking who was suing the most people. So what we did is, for example, SUNY Upstate, for example, is in Syracuse. And we could show, actually, let's do Albany. In Albany County, we did Trinity hospitals. We looked at the 3 hospital systems in Albany County, and we could show that they were suing more people of color than anybody else. It was like majority minority zip codes. And so we would analyze the zip codes of where the defendants were. And then we would write these letters to the hospital. And we do hospital system after hospital system. And it was kind of like, I'm a recovering UAW legal aid staff attorneys health delegate union member. And so we did pattern bargaining. And so we would go to one hospital and say, we'd write these sort of non-demand man letters as a recovering litigator. So instead of saying, we're going to sue you at the end, it was like, we'd like to have a phone call. So, but meanwhile, we had all the evidence how they were suing only poor people essentially and only people of color. And it's not a good look when these hospitals are getting $1 billion a year to incentivize them for complying with our bad old state financial assistance law. And we would say, you got whatever it was, $60 million, New York Presbyterian, and yet you sued 1,400 people. What's up? And look at the zip codes of where these people that you're suing are. And by the way, this other hospital system, NYU, just withdrew all their lawsuits. So don't you want to be as good as NYU? And look at their charity care schedule. So we kept like playing them off each other one by one. We only had one hospital system threaten us with defamation. That would be Northwell. But then after they were on, which is our largest healthcare system, and then after they put us, after they threatened us with defamation, my boss, David Jones, is the world's classiest actor. He's like, oh, that would be great. Think of all the press we'd get if Northwell sued us for defamation. I'm like, I love you, David. They never sued us. Meanwhile, what we then happened is we worked with Brian Rosenthal, a New York Times Pulitzer Prize winning reporter, and got Northwell on the front page of the New York Times for suing 4,000, whatever it was, 4,000, 5,000 people during the pandemic when the courts in New York were closed because, of course, the pandemic was very bad in New York. And they looked so bad that they used a sewer service thing where they would actually not really serve people, like their process server was being sued in federal court for not actually serving people with these lawsuits, and they just was like, okay, we're just out of this business. So instead of suing us for defamation, even though we met with them many times, saying they were like, I can't even tell you some of the things they said to us because maybe I really would get sued for defamation, but anyway, they just some of the things they said to us. I mean, I'll come up to you later. I'll tell you, but anyway. But they just finally just stood down. And that we would see that happen. Even the cancer facility out in Buffalo, the top zip code they sued in had a median income of 87% of poverty. It's a cancer facility. Kelly had a great client story from there. The client that they had on their homepage profiled, they wouldn't give financial assistance to. I mean, it was just unbelievable. So, in New York, the trade groups had a hard time rebutting all this. I mean, like, they are so powerful in New York. I mean, there's no one that spends more money lobbying in New York than Greater New York Hospital Association in 1199. And they were like, yeah. They kept trying to go behind. They wouldn't even put their letterhead on their memos. They wouldn't even do memos of opposition. They would just have these memos, and then we'd have to it's unbelievable. So anyway, I think that was the strategy, was just really getting the data, because it's so hard. I mean, the hard facts are the hard facts, right? You don't have to believe me. You can just believe the data.
No, thank you. Lots of things in there from the corporate campaign angle, the data stuff, the stories. I remember doing this work, and as an organizer, you always collect stories. I didn't think, but in this issue, you can get your stories from court filings, from who is being filed for bankruptcy or for liens or whatever because of.
One hospital had sued 12 people in jail. I'm like, it wasn't John Gotti. That was not the defendant in these cases. I mean, It was really awful. I mean,
I want to ask Nicole about some of the strategies and tactics that you all use in North Carolina, which is a different political environment.
Yes. I'll focus on how we try to keep people at the center of what we try to do. So that is just the stories. And one of our stories was Mr. Terry Belk, and he was someone HM Health had sued. So we had done a little bit of research, not exhausted like you did, but found his name and then actually had him letter write to other people. And that wasn't successful. They probably didn't believe it was him. They probably thought it was a creditor. But so with Mr. Belk, he was really compelling because his wife, who was insured, had breast cancer and they were not able to pay their bills. So HM Health or Advocate Health thought it was a good idea to put a lien on his home and then have his dad go to collections. And his wife ended up passing away anyway. And so then thinking about the work that Undo Medical Debt does and then Dollar for just, we thought that it was a great opportunity for us to work with Community Catalyst on stories to profile Mr. Belk and also Reverend Jackman at Trinity Moravian Church for the less than pennies on the dollar that they were buying all people's debt. And by the way, we went to church there a few weeks ago and saw them burn the debt. That was amazing. Yeah. So Mr. Belk, his story was compelling and got him in local media. But what really turned the tide is that NBC News with Lester Holt got a hold of it. And it was a beautiful story. And there was, the quote from Mr. Belk saying, that he was going to take his debt because he actually ended up having prostate cancer into the afterlife. Gives me chills. So I guess HM Advocate Health didn't like that. So that was part of our pressure campaign to get them to sign on to the program. And so Mr. Bell got a call from them, and they were going to remove the lien, also take his debt out of collections, and not just for him, but everyone else situated similarly to him. And not just North Carolina, but because they're Advocate Health, every state where they were doing that. So this was over 11,000 people. This is beyond the program. And so what I had done previous to that is we did a few things with our coalition. So we had a coalition of medical students and other health professionals and students, but mostly the students driving a letter to the CEOs of the top hospitals. They did not release theirs to the media, but they did get a response from their future employers, essentially. But a letter came from my email to the hospital association and all the CEOs. It was a Black CEO letter, essentially, is what we called it, because we said the whole messaging was, yes, we all worked together on expansion, and they didn't know because of relationships. I knew exactly who was trying to sue HHS, who was complaining to CMS. I knew all of that. And so, the CEO letter was signed by 5 Black CEOs of nonprofit organizations. And so that, and I was nice about it, but I did say, this will be released to the media in the next 2 hours. So just so you know. And so, I didn't get a response from those CEOs, but then we did another one with our coalition partners for our more direct action coalition that's been in existence for a long time. And that letter was saying, let's just go ahead and do the program, let's sign on to it. And then after what happened with Atrium Health / Advocate Health, then other hospitals are saying, we're going to do the same thing. And so then I would write a letter to that hospital, hey, these 2 hospitals are doing that. You're going to do it too. So it ended up that these hospitals went beyond that program because of that, the stories and then sort of that pressure campaign. And the whole thing around the Black CEOs is you talk about health equities, and we know what we're talking about then. Let's just not mix words. And so that was that language. They had to lean into what they say in their mission and vision statements. And so then the other group of, we did faith leaders, pastors, and patients. And so while we were working on those letters, we had people who were actually picked up the phone and calling and saying, Mr. CEO, this is what is happening in my church or in my community. So those are some of the tactics around coalitions and keeping people at the center.
Go ahead.
I was just going to say, I think one of the things I really want to make it very clear, like CSS, my organization was in partnership with incredible partners, AARP, Consumer Reports, Northwest Bronx Clergy Coalition, the Labor Religion Coalition. I think it was just such a Make the Road New York, South Asian Council for Social Service. It was just an incredibly broad, geographically diverse groups. It was just, it's so powerful when all of those groups are united. NIPERG, sorry, I didn't mean to forget the PERGs. Anyway, it was incredible. Originally, in the early days, RIP Medical Debt would support us and on our work. And it was really, really powerful and it made a big difference to have these memos of support from, 30 organizations.
Yeah, I'm loving some of the themes here, both of coalition, but also being grounded in specific communities, whether it's, immigrant community, communities of color, the building of relationships through other campaigns. I actually thought one more thing with regard to North Carolina, both in terms of how this played off of the fight that I know that North Carolina Justice Center did off of the Medicaid expansion fight and those relationships built, and also the role of the governor and I think from afar we saw that he played a leadership role, and you can tell us how much of that, how much, and what was the relationship and working together with a champ.
Yeah.
When you have a champion, how do you use them?
Yeah, that's great. I mean, Governor Cooper he became one of the most popular people wherever we went, in the country. They would talk about Governor Cooper. But yeah, day one, that was his priority, and lawmakers didn't like him. He used to be one of them. He was in the General Assembly and he was the AG, and he is from Rocky Mount. His mom was a teacher. He has a way, he has like a lot of, and he was a lawyer, but a lot of charisma, and really strategic. And so he doing this program, going around the legislature, that didn't get him any favors for that. But at the end, you can see him saying, you know what, I'm out of here. I couldn't even take a vacation because he didn't want the lieutenant governor to become our governor for any time. And so, I probably shouldn't have said that, but we're not on Facebook Live, right? For him to take that on, and then with Secretary Cody Kinsley, for them to be together, but also we knew where, I'll say, progressive people were on this issue for a while on expansion and then medical debt, right? But also a lot of people in the conservative party and in leadership as health chairs, those relationships were very strong. And so I think that also helped. And for me with relationships is I am a retired elected official. So helping to run a small affluent town outside of Raleigh and having relationships, I always had both name tags, and I just roll up in there like, we represent same people. And I would just start talking to people like, oh, you were a mayor? Oh, and they'd be like, yeah, they don't know how to do stuff here unless you were local. I know, right? You just use those relationships to get people to trust you. So in that case, then you have people providing information to you that normally you wouldn't ever have, and getting things to you embargoed. That's how we were able to defeat the whole casinos, building a casino in North Carolina with what money? Expansion money, And then just this program called the NC Leadership Forum is what the folks on my team, like Rebecca and Han, really feel like that is what helped me with these relationships, because in that room, I feel like we were almost a shadow committee of the General Assembly. It started out with all these issue areas, and it's like conservative people and progressive people who are considered health leaders. But at the end, it was expansion. It was, advanced nurse practitioners, for example, and then certificate of need at the end. But I was able to use one of our stories and then show at the end how this woman of color died because she wasn't listened to by her provider, and so did her baby. And when she didn't have a baby anymore, they snatched her Medicaid. So, just to share that story in the room, all these folks who were like, the Speaker of the Houses, Chief of Staff, Deputy Chief of Staff, hospital CEOs, Chambers of Commerce, county commissioners, there was just like in the room from everyone. And at the end, the question was, is there anyone who does not support Medicaid expansion? And no one said that. And so we got a lot of people who did signed on, and they said it's because they got a chance to learn from me, and we were all on first name basis too. And I told every Republican lawmaker that I would come and see them the first day of session. And every first day of session, I go around and talk to each one of them. And that's how I was able to draft the medical debt bill. I never had an opportunity to draft anything with anyone. So
thank you so much. Maanasa, can you tell us from your vantage point some of the other trends that you see with regard to strategies or tactics?
Sure. I think now that we're talking about what's been going on, I think it might be helpful to think about what the gaps, or maybe you can call them opportunities, are moving forward. I think it's helpful to think about them in maybe three buckets. So there's first of all, even the states that are really ahead in the game, there's still substantive sort of standards gaps, right? You've got population carve-outs, you've got provider carve-outs, and you've got debt type carve-outs. So it's like you've got populations, you might exclude immigrant populations or not explicitly tell hospitals to provide these services to immigrant populations. You might have, folks who are who have faced a lot of medical expenses, out-of-pocket medical expenses, but might not qualify under the income threshold. They might be kind of left out. And I know New York recently closed that gap. And then there is, of course, the provider, gap. I think the newer bills, we're starting to see a little bit more to be a little bit broader, but are you covering hospital outpatient departments? Are you covering physician, groups? Are you covering ambulances? They're the big carve out of NSA. Yes, exactly. So ambulance bills and then labs, imaging, all of that stuff. So kind of being more holistic in that approach. And then the debt type, of course. I mean, a lot of this debt goes on credit cards, whether it's medical credit cards or general purpose credit cards. You've got all these buy now, pay later plans and various medical financing products. How are you covering debt in those vehicles? Then you've got your procedural gaps, which is like wonky and no one wants to talk about this, but as I already mentioned, it's like the burdensome financial assistance process is like a major one. And then of course there's a lot of weak speed bumps before proceeding to collections and lawsuits. States have tried to kind of add these guardrails, like you need to do the screening or like whatever, but it's kind of like few states do this, and like I don't know how well any of it is happening in practice. So there's sort of like that is an issue. And then court process kind of came up. Elisabeth was talking about it a little bit, but default judgments are a huge problem. It's like an assembly line. So it doesn't matter what standards you have. If that information is somehow not being transferred over to the judge, that, they're protected in some way, like nothing's going to happen. You're going to get that default judgment. So that entire like line, there needs to be like a fix there where, they have to either attest in their complaint or whatever, that, they've done the screenings required by the state. So just kind of preserving those protections. And the third biggest gap is, of course, like enforcement and oversight, which I know Luvia was talking about a little bit earlier. This is like one of the major things is jurisdiction problem, right? So it's like, there's the departments of health are hospital regulators, and they're license them and have a variety of there's a varying level of cozy relationship between departments of health and the regulated entities. There is the Attorney General's office. If they make it their thing, like Keith Ellison did in Minnesota, great, we get some movement. I think we saw that in Washington as well. But if they don't, and that's like deprioritized, you're not going to get much movement from them in terms of like enforcing a lot of the consumer protections side of things. And then lastly, and this is a little bit wonky too, but like there's just no oversight or understanding of like the tech and the AI tools that are being used, especially predictive analytics, to kind of, so a lot of hospitals kind of subcontract with revenue cycle management companies, which are largely, all have a lot of private equity investment kind of rolling through them. And they use various predictive analytics tools to figure out who to sue and whom to go after more. And sometimes they use this for the good, which is to figure out, who should be eligible for financial assistance, but at other times they use a propensity to pay score, which is who are you likely going to get squeeze money out of, and they kind of go after those people, which is the way that we don't want it to be. And so there's like the lack of transparency in that space, I think, is like something that we should be kind of shedding some light on.
Great. That adds to this agenda of like what can and should be done at the states, and I may ask our other panelists to talk about what's next up on queue in their states, but I want to open this up to the audience because I know there's tons of questions out there, and I see people already raising their hands, so let's just get to it, and then we'll see them. But I have tons of questions if you don't, but I don't think this is a shy group.
Yeah. Hi, Zoe Gallagher with Economic Action Maryland Fund. This question's for Elisabeth. So we were able to, in Maryland, pass a bill to ban adverse credit reporting, but at the last minute, Care Credit and other medical debt credit card companies were able to get themselves exempt. I guess I was wondering if you faced similar challenges, like how you were able to get them added in.
We did. I mean, I'm sorry for every state that came after us because we were able to include Care Credit because it was all happening so fast. I think our governor, I didn't mention it, but our governor had been she is the accidental governor. Andrew Cuomo went down in disgrace. And so our governor is Kathy Hochul. And this is something she really did embrace. So she wasn't a Roy Cooper, but she did come to our office to sign the credit reporting bill. And it was really exciting. And I think it was, Colorado hadn't I think for some reason Colorado couldn't deal with it, but the original credit card companies came to us and the reason why I was at APRENT is the original ones made a pretty good case. And I wish I'd called Fred, by the way, from Urban Institute, because they made the case that how can you segregate a Starbucks charge from a medical charge? And when you're suing for like $1,000 end of the month bill that hasn't been paid. And we thought, gee, they might be right about that. And so we gave up on regular credit cards right away. But we said, but medical credit cards, working with our colleagues at the National Consumer Law Center, again, Chi-Chi Wu, my hero, or Shiro, said we were able to make a really good case that, care credit cards are for medical care. Towards the end of it, they tried to say, well, you could use it at the pharmacy to buy bubble gum at the same time. We're like, it's really not what they're for. And we had enough cases where like doctors and dentists and opticians had sort of creepily said, sign this, we'll do a prior authorization request in one case or something else, like really. And then people suddenly found themselves with these 26% interest rates. And we had to go to like a charity, the Sussman Trust, to get like that dental bill paid and stuff like that. So we had enough of those little cases to kind of beat it back, but it was all moving so fast because it was the end of session and, everybody kind of wanted to catch up with Colorado and, and so I think we just got kind of lucky. I would love to say it was my brilliant reasoning, but I think it was really, we were able to keep care credit in. And then they, I think, really woke up with that. And I don't know how, I was so disappointed with, I was really disappointed that CFPB like caved on care credit. I don't know why they did, but I thought it was pretty clear. It's for medical care. Like that's what they say they're for. Why should they be exempted?
Yeah, no, in California, that was actually the argument they used to say, if you want to codify the federal rules, that's fine, but don't go beyond them. And in fact, our legislative change committee was willing to tank the whole bill, but then at the end of the day didn't, and probably better because now with the CFPB proposal not going forward, then that at least provided that protection. But
it wasn't even a twinkle in CFPB's eye.
Right, at the time.
Early 23, so I don't think that came along.
Well, oh, yes, next question.
Yeah, hi, Ed Weisbart from Physicians for a National Health Program. I'm wondering if you have any, I live in Missouri, and I spent a lot of time speaking across the political aisle, and I'm wondering if you have any insights into how to get your sort of strategies to be embraced by more conservative members of your state legislature?
Both Nicole and Luvia were talking about that. Once you get outside the big city.
I'll say that I think most of us have been saying the importance of the stories, and making sure that the stories also are somewhat diverse. Two, I think even being able to organize within the legislators. We are very fortunate in Illinois that we have a lot of great champions when it comes to our state legislature. Some of them are actually former colleagues. So it's sometimes it's also that way. So kind of like the internal as well as external strategy. But I think as much as you're able to make it about issues that they care about. So for us, again, it wasn't about the immigrant issue. It was about the uninsured. And it was about those that are low income. I know that across the states, there has been more interest around just consumer rights. So maybe it's just changing it a little bit, again, depending on who the audience is. For us, it was about the uninsured. But I know according to our state legislators, there's across the aisle, it's about consumers. So for me, I think I would say it's both, again, the internal, external, as well as the messaging.
Nicole?
I think it's a great question. I do think that being in that leadership forum that I was in helped people who may have had an opinion about the Justice Center or about me, oh, that's that left-leaning place. And, and I never describe myself because I feel like you're unbalanced if you're leaning over to the left. So, I just describe myself as being progressive, and we don't describe our work that way. So I think that was one of them. And then for me, I started thinking about, I can't just talk to our friends, and we can't ignore our friends either. Whoever's in power, you can't just ignore the other party either. So just really continuing to talk to the minority leaders and let them know what we were doing, and then saying, hey, we want to provide questions to you, even though the other folks are not going to let you really run an amendment. And then when I talk to the other folks, for some I trust, I have told them, I have given certain questions, and I this is very narrow. I probably with 2 people I would have done this with, to say, I'm going to provide you the exact questions, but here's the amendment, and I want you to push for this amendment, Mr. Health Chair. And that has happened related to managed care. I think the other thing is thinking about stop making assumptions myself about people. So, for example, it is challenging to see people who, and I'm a person of faith, but when you pray at the beginning of session and you do everything to tear down the people that God talks about, it's a problem for me. And when red lines for us is like women's health. And can we just say that the head is attached to the body? Why do we have dental health and visual health and reproductive health and health? Like, can we just stop doing that? But I decided that was disrespectful to the people impacted, to the people who invest in our work, and to our colleagues, to not walk into the Freedom Caucus member's office and say, here's our information on this particular bill. What do you think about this? And so we took those chances and just pretend that yesterday didn't just do something terrible, but I'm in here today because people are working and I'm in here. This is my work. Our other people have clients, and our clients are the people in North Carolina. And we did have someone who leads the Freedom Caucus to remove his name from a bill. So, and then we went back to him and said, would you take this information on medical debt? They not only took it, but actually voted on it in the Freedom Caucus and said it was going to be a priority for them in this session. So those are the kind of things I think we just have to remind ourselves is to through this and get through what happened yesterday to tear down low-income communities and women's reproductive rights.
Just to quickly add on to Nicole's, I heard the Treasurer Dale Folwell speak. He was like a one-man tour de force in North Carolina for a long time. And I just remember him mentioning how he was moved by his faith, essentially. And he thought it was deeply unchristian that anybody was getting into medical debt at all, which I thought was, I was like, yeah, it's great. Yeah.
Very not unlocked by the speaker. And so when we started working with the bill filer, the speaker pretty much said, stop. I'm not going to let this bill go, which it had already passed unanimously through the Senate, and there was one absence. And so it's because of relationships. And so that's when we decided to stop and just do the groundswell of support.
It is interesting. I mean, as opposed to the broader philosophical questions of what is the role of, government and healthcare, this is very grounded and visceral, right? Like you have a person with the debt, and hopefully it's a way that brings people into the broader conversations. But
there
it has
isn't a person in this room that hasn't been frustrated with a medical bill, and that's true in the legislature too. It's just medical
among
billing.
the staffers.
It's just like it's just like So
we have another. Yes.
We've been talking a lot about state policies that address provider billing, but have there been any interesting state policies to address regulations on insurance companies or gaps like higher copays and deductibles and that kind of thing?
We did something that our insurance industry didn't like very much. After we've been winning all these medical debt bills, we thought we really started looking a lot closer at insurance design, because I think insurance is designed poorly, right? When you have a deductible, you don't have people getting insulin, for example. And why would you have any dollar copay attached to insulin? And there have been all this discussion in Washington, even in our own state, we had done like $100 a month cap and stuff like that. And so we went to the superintendent of financial services under the Cuomo administration, a woman named Adrienne Harris. And Superintendent Harris, we said, why don't you do something really radical? Why don't you go for $0 copay for all state regulated insurance products in New York for insulin? And she was like, and I made the case that, diabetes disproportionately impacts people of color, but also low income people, very much a huge issue for rural white New Yorkers. It was a great issue that had a lot of traction, and she went for it, and she got the governor, and her whole department staff was like really mad because it's extremely hard to implement a single insurance mandate like that basically overnight, but she did it. And so I think we would really like to start looking more at insurance product design, like why if medication adherence is so tied in with medical debt, why are we having any deductibles for things like insulin, sick visits? Like, everything in our current system is just forcing people into hospitals because of the deductible, right? You wait till you get super, super sick, and you're not, because it's, you don't want to go to the doctor, urgent care. So I think really we should all be looking closer at insurance design. And we are fortunate, in our 1332 waiver, we got rid of a bunch of cost sharing within that effort. And I know the DC Exchange has done a lot of great work in this area about redesigning their insurance products and what is pre-deductible, accessible or not. So.
Yeah. No, I think that the Affordable Care Act provides a scaffolding that I think states can work on, whether it's standardized benefits and additional subsidies like California and other states like Colorado have been doing, and other efforts to try to get into the world of employer-based coverage is something that is. So, do you want to say a second about that?
Bring up. I was like, we do a lot of the tracking of coverage policies as well, and states have been, very active and been doing a lot. But at the end of the day, it's like the majority of people are covered under ERISA governed plans, and there has been, limited to no movement. I know they've done some good things in mental health parity and stuff like that, which God knows where that's going to go now. But yeah, I think that's like a major block either way to really tackling the insurance problem.
Michelle from Community Catalyst.
Yes. As we segue into federal solutions, I'm really interested in if there have been any unintended consequences of state policies regarding medical debt, where you've been like, oh, I didn't realize that was going to happen. That actually hurts. Or that is, and this is related to a conversation we've had together where there are some even potentially well-meaning staffers on the Hill who are nervous, for example, about having a floor for financial assistance. They're like, if that happens to the hospitals, then the insurance companies are going to go and they're going to increase their prices because, patients aren't going to, or they're going to cut their reimbursement to hospitals because patients aren't going to really care, and patients can't cost shift because if they have certain financial assistance, and the whole ripple effect. That's just one example of like where we're getting it. So I'm just wondering, as we look at it, are there cases where you're like, oh, that was designed in a way that we didn't anticipate, that it was actually negative? And then conversely, if you have evidence that it was actually great, let's talk afterwards about continuing to uplift that, because we're getting.
I think the research, and I think there's a lot of researchers in this room, will say there's a real myth around cost shifting and whether that's really occurring or not. And so I would really invite people to revisit that whole myth. And I would say, to answer to your original question, no, we have seen no unintended consequences. We've been really thrilled with our work. And the impact on it. I'm sorry. I know that sounds so arrogant. I didn't mean it that way.
Question there, but go ahead.
Vague. Maybe, I don't know if this is a theory or something that's happening, but I do know that a lot of the times hospitals and debt collectors use the threat of two things, right? It's either I'm going to put it on your credit report, I'm going to sue you to kind of get paid back. And there's been, ideas in the air that putting the credit reporting bans out there is going to increase the amount of litigation. I don't have any evidence that it's happening, but I would love to hear from legal services advocates and what they see on the ground and on the basis of that.
I mean, the one thing that I have heard is sometimes when, like, a couple of things go viral in California, where the law in California sets that somebody who's under 400% of poverty level can't get charged more than the Medicaid or Medicare rate, and so then there. If people notice that, then there's people who are above that who are actually paying a much higher rate, maybe because of the design of their insurance. And so if you're insured, and then you're actually paying more than if you're uninsured there. But I think that's a problem that is about the broader structure, and we need to solve that broader structural system rather than take it away from the people who need it. But that's a very small piece. Barack.
So. Both you and I think a previous panel talked about the proliferation of wage garnishments that have accrued from medical debt lawsuits. Have any of you engaged with the business community, in particular large employers in the retail sector, about trying to combat those garnishments? Because I imagine they're not crazy about doing that to their own employees.
No, I mean, we did it. We analyzed the 5 hospitals' wage garnishment practices and issued a report on that. And it was hard to get that data. And it really didn't tell you very much about the defendants. But the one thing it told you is who they worked for. And I can tell you Goldman Sachs was not on that list. It was, school districts, the hospitals themselves, union factories, local mom and pops, little, TGIFs. And so you could just tell. And then I would, this is like the worst. Fred, close your ears. People, any researcher in here, close your ears, because what I would do is I would look up on Idealist, like the offering wages at these various places. And that was our analytics. And so I would look, and that's how we would figure out these are all low wage workers. And that's when we got rid of wage garnishments. That one went along. And then the liens, the hospitals themselves reported on those and made them, why were they taking 2,400 liens a year? It just looked bad.
We were just talking about this with another researcher and a legal professor the other day who works in consumer protection laws. And a lot of large employers just use payroll processor. So it's kind of just automated anyway. So they don't really have the pressure point. When you come to bank account garnishment, you might have more like pressure points because it's like, if it goes into a joint bank account, what happens? And there's a lot more like that nuance that they have to deal with when it comes to that kind of thing. So banks are not thrilled about that, is what I hear. But for whatever purposes, like employers seem not particularly bothered by it.
Before you guys go, I just want to give you a last word, like seconds, not minutes, on this. Like, what's next for y'all? Like, what's the big thing that you're coming up on? You mentioned some gaps. I don't know if there's anything else. So anything else?
We have an updated report coming up soon, so keep an eye out for it.
Keep an eye for it. All right, great.
We're going to hold a stakeholder, like a work session. All the folks who say like it's just not just the hospitals, but other entities that impact high prices cost for healthcare. So bring them together and let's find a solution together.
For us, this year we launched a multi-year campaign when it comes to outsourced care. I think many of us know that unfortunately across the country, more hospitals are outsourcing care, whether it be emergency departments or certain services, and those things are not covered under hospitals' financial assistance policy. So as a result, the person goes to the ER. All they care about getting stabilized, and all of a sudden, when they get discharged, they know that they find out that the anesthesiologist is not on staff, etc. So we're trying to hold hospitals accountable that if they are going to choose to do that, then those services have to be covered under hospital financial assistance. It's a big fight. So that's what we're saying. It's a multi-year campaign, but it's important to our community, especially with now what's going on at the federal level.
And we're working on a No Blank Checks Act. I think every person in this room, if you've gone to a doctor in the last couple of years, you've been asked to assign an assumption unlimited financial liability, even though at that moment you don't know what they're going to do to you and how much it's going to cost and whether your insurance is going to pay it, or if you're essentially indemnifying that provider for their billing errors, right? Because you've just assumed all financial liability. So we're going for trying to get a standardized assumption of financial liability form issued by the Superintendent of Financial Services that does not guarantee unlimited financial liability. So it's a challenge, but we would be the first state to do it if we win. So No Blank Checks Act. That's us.
Great. Well, so I want to say this gives me hope, and especially in a time of, again, where what's happening at the federal level, it can be very, very bleak. Like you see what's happening, and I think the 2 lessons I come away with is that the power of persistence. These are multi-year campaigns, each one building on each other, and that at the end of the day, progress is possible. And it may be at the state level for a long time, and then sometimes it breaks through at the national level. But just give them a great round of applause for their great work. I'll hand it to our Vikas. Hand it to our host.